Our next speaker is Dr. Varma. He's joining us from the Cleveland Clinic. He did his initial training in the UK and then did his EP fellowship at Beth Israel. Welcome.
So, thank you very much. Good morning, ladies and gentlemen. And I'd like to thank Dr. Lakhireddy for inviting me to this splendid symposium. It's a pleasure to be here. So I'm going to try and identify who is the right CRT candidate. This really is a patient selection conundrum, and it's becoming more and more interesting as well as more and more difficult. So what are we trying to do here? We're trying to address heart failure mortality. And as the left ventricle remodels, and the left ventricle dilates, ejection fraction drops, functional class deteriorates, mortality increases. Ejection fraction is less than 20%, functional class 4 has a 2-year mortality rate of almost 50%. So this is really a disease like a cancer. It has a greater morbidity and mortality than many tumors, but it's not always regarded as. So how can we address this? We know that as remodeling occurs, that functional class deteriorates and sudden cardiac death risk decreases, but that is taken care of with defibrillator therapy. Pump function as a factor in mortality increases. Coincidentally, the incidence of a prolonged QRS also increases. It increases to almost 30% once functional class is deteriorated. Perhaps there's an association. And this was the rationale for CRT initially, really applied to left bundle branch block. On the right, you see a schematic where you see slow transeptal conduction, slow interventricular conduction, and late activated posterolateral left ventricle. That is the basis of a wide QRS, electrical dyssynchrony. This leads to mechanical dyssynchrony, intraventricular and interventricular dyssynchrony, which reduces pump function. However, all of our methods for identifying dyssynchrony as a selection criterion for CRT have not been conclusive. So this has really been abandoned for the time being, at least, as an identification of the right candidate. Electrical dyssynchrony is what we're working with, and this has become more and more important. So the initial trials really addressed class 3 and class 4 heart failure, and the major ones were Companion and Care HF. Okay. I was trying to locate the cursor on this. In any case, the top table shows the results of these trials. Large trials. Okay, doesn't work very well. All right. So anyway, CRT was found to confer a survival benefit, importantly incremental to best pharmacotherapy. And you see down here that we have the various drug trials that have come through with ACE inhibition and beta blockers and aldosterone inhibitors, all of which have impacted heart failure mortality. But CRT is additional to that. It improves mortality from those trials of more than 30% in this group. So it's a very important therapy. And attention has really become directed to expanding the indications to be more inclusive and also identifying the right candidates. So the ideal candidate, to recap, in 2008 was a patient with an ejection fraction less than 35%, a QRS duration, whatever pattern, of more than 120 milliseconds, sinus rhythm, and class 3 and class 4 heart failure. However, there was a significant non-response rate, which Dr. Dober addressed earlier on, almost 30%. So can we reduce that as well as increase indications for CRT so more people can benefit from this potentially life-saving therapy? So certain guidelines have addressed the data that have come out in the last 3 or 4 years on this topic, in the US in 2012 and more recently in 2013 from the ESC. And they have really addressed some of the major trials data that have emerged, addressing heart failure class 1 and 2. So although heart failure mortality is less when functional class is better, these patients are still vulnerable to heart failure hospitalization which is a significant source of morbidity, and perhaps intervening earlier prevents the remodeling process. Attention is focused on the QRS itself, both width and the morphology, the impact of atrial fibrillation, of RV pacing, attention to the LV lead, because we deliver the LV lead according to the patient's anatomy, and sometimes this may actually determine the response. So the patient himself has the patient's anatomy for the coronary sinus tributaries has an effect on his ultimate outcome. And then non-electrical factors have become identified, comorbidities. Many of these are unknown, but they also play a part. And renal dysfunction and gender have become increasingly important. So addressing class 1 and class 2 patients. So 3 very large trials, much larger than the initial trials 10 years ago for class 3 and class 4 heart failure, looking at patients with an ejection fraction of less than 30%, and looking at all-cause mortality and also heart failure hospitalizations. So MADIT CRT, provided seminal data for this. It was the largest trial, and this found survival-free from heart failure events was reduced by 34%, a significant reduction in a short time period. And this was really provided by heart failure hospitalizations. The mortality was relatively low in this group. Importantly, although these trials enrolled class 1 patients, there were a minority, only 18% in reverse and 15% in MADIT CRT. There were no definitive outcomes from this group of patients. The trial highlighted the importance of QRS morphology. Efficacy of CRT depends on QRS morphology. We see here that for left bundle branch block, the modeled schematic that I showed you earlier, CRT therapy reduced the probability of heart failure or death very significantly. In fact, most of the positive effects of the trial were concentrated in this group of patients, because in the non-left bundle branch block patients, there was no effect. There was no difference for CRT-D therapy. Non-left bundle is right bundle and IVCDs, and you see no effect for right bundles in the left panel. And you see for IVCDs a trend possibly towards worsening. So the effects of CRT are concentrated in left bundle branch block, and they can be observed within 12 months. And here the remodeling data, or the reverse effects on remodeling, reduction in LV volumes on the left, improvement in ejection fraction of approximately 12%, concentrated in the left bundle patients. And this is also from MADIT CRT. Male-female difference here, which I'll address a little later. But going back to the QRS less than 150 had a less effect, a less positive effect from CRT. Most of the positive effects were concentrated with longer QRSs. So why is that? The longer the QRS, the wider it is, the more electrical dyssynchrony there should be. So then it makes sense that there's no benefit of CRT for QRSs of less than 120 to 149. And this was observed in all the class 1 and 2 trials. And retrospectively, looking at the earlier trials, the class 3 and 4 heart failure trials, in a meta-analysis, again, there was very little effect, if any, when the QRS was less than 150 milliseconds. So the 150 mark seems to be important. Similarly, there was no benefit in non-left bundle branch block patients. A word of caution here, though, because most patients who have non-left bundle have QRSs of less than 150 milliseconds. So there's a little overlap here. We don't really know very much about left bundle patients who have QRSs less than 150, or non-left bundle patients with a QRS of more than 150. So this needs to be addressed in the future. Why is that important? Going back to the schematic, the actual LV activation delay seems to be important. That's tightly related to the QRS duration in left bundle branch block, not in non-left bundle branch patients. When you actually measure that activation delay from the onset of the QRS to the latest activated LV site, when that number is more than 95 milliseconds, there was a very much increased chance of response. And this is from the SMART AV trial, published by Mike Gold as first author. So why is that important? Well, when you look at LV activation times, according to QRS duration, Well, on the left, you see normal patients. Nobody has an LV activation time in excess of 100 milliseconds. If you look on the right, patients with left bundle branch block, almost all of them have an activation time of more than 100 milliseconds. But if you look at right bundle branch block, that's the third box there, it's split half-half. So you have a 50% chance of having a positive benefit when you have right bundle branch block pattern with a wider QRS of more than 150 milliseconds. So this is the interaction between QRS morphology and duration, and some of this has not been explored. But the updated indications account for this. So class 1 recommendations now: ejection fraction less than 35%, sinus rhythm as before, left bundle branch block, not just a wide QRS, left bundle branch block, duration of more than 150 milliseconds. Also now inclusive of class 2 heart failure, reflecting the large trials that have been published recently. Class 2A recommendation for left bundle and QRS of 120 to 149. As I mentioned, some of these data are not very clear yet. This is class 2A in the States. That is, it can be useful, but it's regarded as class 1, a recommendation in the European guidelines. So an area of dissent, reflecting that we actually don't have all certain answers here. A new recommendation for non-left bundle branch block patients with a QRS of more than 150, because they're more predisposed to having LV activation delays. So, what about atrial fibrillation? Very few data here. In fact, the very first CRT trial, MUSTIC AF, which is approximately 15 years old now in design, is the only randomized trial to address this. We have very few data. But the recommendations recognize that many patients do benefit. But they have to be committed to ventricular pacing. As was shown earlier, patients with fibrillation often have fusion, have reduced levels of ventricular pacing. So there's no point in implanting a biventricular device if it's not going to pace effectively. So the new guidelines suggest that a CRT can be useful in patients with AF if the patient requires ventricular pacing or otherwise meets CRT criteria, or if they require AV nodal ablation or pharmacological rate control, to commit them to almost 100% ventricular pacing with CRT. So this is very important. The new guidelines don't take into account functional class, but this is based on an EF of 35%. This is exposed with a little bit more clarity in the European guidelines here, and on the right you see patients with a reduced EF and an uncontrollable heart rate, and any QRS duration should be committed to AVJ ablation CRT. And on the left, they do include functional class. If the QRS is more than 120, on the left there, CRT is indicated, but they have to be committed to ventricular pacing. If the QRS is less than 120, and you have adequate rate control, then they don't need CRT. However, if you have inadequate rate control, then again, AVJ ablation and CRT. But very few data for atrial fibrillation, but many patients do respond. What about a need for right ventricular pacing? And this often comes up. So this is a patient, progressive tiredness over years, now limited to one flight of stairs, low ejection fraction, ischemic cardiomyopathy, residual ischemia, QRS less than 120. So the patient's indicated for a prophylactic ICD, a dual chamber ICD, in view of the chronotropic incompetence to pace the atrium. What is unknown is what happens to the AV interval. If the AV interval increases, then they may be committed to ventricular pacing. Or there are algorithms that protect from ventricular pacing, so you can just commit them to atrial pacing. And this is relatively unknown. So you have to pace the atrium and see. Why is right ventricular pacing poor? Well, in the top right insert, you see from the David study that when you have unnecessary right ventricular pacing, for instance, in the case I just illustrated, then mortality increases. Well, why should that be? Well, going back to the schematic on the left here, when you pace the right ventricular apex, it's just like left bundle branch block. Or is it? Actually, it's worse, because the interventricular conduction is worse, the QRS is wider, so it's a worse condition. So we want to avoid right ventricular pacing. However, there are very few data here. If you look at the first two trials, there are 30 patients and 60 patients enrolled in those for de novo CRT versus RV apical pacing. very few data. Block heart failure, which was published recently, a larger series of patients, but in patients with better preserved ejection fraction of more than 40%, 40 to 45%, showing benefit. So again, we really don't know which patients to select, but we can use CRT. Class 2A can be useful for patients on best medical therapy with an anticipated requirement for significant ventricular pacing, significant described as more than 40%. And this is a modified recommendation. Before it was a 2B indication, but now it's recognized as can be useful. So this is something to be aware of. What about patients who are already committed to RV pacing? No data there, only single center studies. And this is one, and showing that you have a very wide QRS during right ventricular pacing in heart failure. It's worse than the worse LV conduction delay than occurs in left bundle branch block. And actually, if you upgrade them, most of these patients do very well. They do very well when you abbreviate the QRS. The usual factors of QRS duration, female gender, non-ischemic cardiomyopathy do not apply in this condition. But these features need to be addressed prospectively. No data just now. Comorbidities, increasing interest in this. And I can't point to it, but as you see, that line decreased, the linear line represents GFR. As it declines, then all-cause mortality, those are the white bars, increases dramatically. So a question arises, should we be implanting ICDs in patients with renal failure? Because prophylactic ICDs at least. Because the nature of the disease process itself, this comorbidity, is likely to overtake the arrhythmic risk. So this is a very interesting question. But for CRT, we have very few data. In fact, they're conflicting. We know that chronic kidney disease is common in patients undergoing CRT. It's an accompanying comorbidity with high frequency, and it's associated with a higher mortality. But if you implant a CRT device, it may improve renal function. Some series show this. Again, no large data sets, so the jury is out on this. What about right ventricular failure? We know that that predisposes to a poorer prognosis generally in the heart failure population. What's the impact of CRT here? Well, in one study in the top, right ventricular dysfunction is a powerful determinant of prognosis, but it did not diminish the prognostic benefits of CRT. This is from CARE-HF trial, class 3, class 4 heart failure patients, relatively sick patients. And in the bottom, we see from MADE-IT CRT again, CRT was associated with an improvement in right ventricular failure. So right heart failure is not something we understand very well, but it's not a cause to preclude CRT. What about gender? Very interesting topic here, very interesting data from MADE-IT CRT. And when reanalyzed, some of the class 3, class 4 heart failure trials showed the same thing. The probability of improvement is much higher in women. In fact, from MADE-IT CRT, the probability of death was not decreased by CRT-D versus ICD. Most of the positive effects in this trial were concentrated in women. So regrettably, I have to say that having a male gender is a significant comorbidity. LV pacing lead position, an area of intense interest. Non-apical positions have been shown to be ineffective in two major trials. And it's actually achieved a class 2A indication. So the apical lead positions have been shown to have higher mortality, leading to non-apical preference for positions. So this is a class 2A indication in the European guidelines. We prefer lateral. We don't know about the anterior positions. It becomes very complicated because in ischemic patients, to avoid posterolateral scar, there's no point in pacing into scar. But we don't have many prospective data on this. We don't routinely look for scar and then cite our lead accordingly. We don't have choices with lead positions either, particularly when we implant endocardially via the CS to an epicardial location. Site of maximal mechanical delay may be a relatively beneficial position. Maybe the effects of pacing matter, the pace QRS, the morphology, the duration. Abbreviation may correlate improvement. Widening certainly correlates with deterioration. Perhaps we need multi-site pacing, Dr. Leclerc's slide that was shown earlier. Perhaps we need endocardial pacing, especially in non-responders. These are areas of intense investigations. So each individual patient has his own set of limitations and possibilities for delivering an LV lead position. It becomes very, very complicated because, after all, this is an electrical therapy for an electrical condition. And when you look at the electrical effects, and this is non-invasive mapping of a patient receiving a BiV device with a quadrupolar lead. On the left, you see intrinsic conduction. Red means early activation, blue is late. Two different views, anteroposterior on the top, left lateral on the bottom. And in the bottom, you see that blue area of the posterolateral LV signifies late activation. It is equivalent to the schematic that I had shown you earlier, but this is a real-life patient. The red is early activation. Above, you see the right ventricle is activated. And we don't need to go through the details, but you see that the different pacing sites, and these are only a matter of a centimeter or two apart, can vastly change LV activation sequence. So lead position may matter. Perhaps you don't need to shift the positions very widely in order to change activation sequence. So lead positions are very interesting, but becoming more difficult to understand. So a summary of new changes. Class 1 indications. There are limitations to QRS of more than 150 with left bundle branch block. Expansion to Class 2 patients with left bundle branch block and QRS more than 150. A qualification. Class 4 heart failure patients, really only about 10% of the trials have to be ambulatory status. There's an addition of a 2B status. The European guidelines did not accept this, but this is Class 1 heart failure, ischemic cardiomyopathy, sinus rhythm, left bundle more than 150. There's a restriction. CRT is not recommended for patients with Class 1 or 2 patients with non-left bundle less than 150. And it's not indicated for patients whose comorbidities and or frailty limit survival to less than 1 year, recognizing the major influence of comorbidities. But many of those are still unknown just now. So in conclusion, I'd like to suggest that regarding the question of who is the optimal CRT candidate, the highest level of response is in those patients with a wider QRS with the left bundle morphology, females, non-ischemic cardiomyopathy, without comorbidities such as atrial fibrillation, renal dysfunction, right heart failure. And if you're male with ischemic disease and narrow QRS and non-left bundle morphologies, you're really at the bottom of the pile, unfortunately. Thank you very much.